Three favorite topics in EMS are, anyone want to guess number one?
Cardiac.
Documentation?
Documentation is number two. What's my third? No.
Ethics.
I hate trauma. Huh?
Ethics.
No, close, medical legal. Okay? I am weird. I am not your average duck. Okay? When I was hired as so I've been a paramedic since 1998. My first EMS certification was in 1989. I was a emergency trauma technician in Alaska, which is equivalent here to an EMR, emergency medical responder, which you have some knowledge, but you can't actually do anything, okay? I did that because back in the 80s, when I started in the fire service, it was not cool to do EMS. And all the fire dogs I was around loathed EMS, so I guess I'll loathe EMS because that was the way it was. So when I got my degree in fire service administration, I had to take an EMS elective. So I said, okay, what's the easiest one and the cheapest one to get through? And there was EMT for 5 credits or ETT for 3. So I did ETT because it was cheaper and I didn't have to do anything, and I could say I did my EMS, but still pretend to, and I did. I didn't like EMS at the time. When I came here in 1995, I quickly realized you better get with the program because EMS is the future of emergency services. As you guys are probably figuring out, except for maybe in July and August, we are emergency medical services departments who occasionally get to go put out fires. That's the reality, okay? So I became an EMT in 1991. I became Washington State EMT in 1995. Then I was an IV tech, and then I went to paramedic school and became a paramedic in 1998. In 1999, I was asked to start teaching at the paramedic program at CBC, and for 12 years I ran the paramedic program at CBC. And I always did 3 classes. There was 3 that nobody else taught but me. One was documentation, the other one was medical legal, and then the 4th one was cardiac. I actually loved documentation. When I was promoted to captain and then the EMS officer for the Kennewick Fire Department, Chief Hines asked me in my interview, what are the top 3 priorities that need to happen for the Kennewick Fire Department? And I said, number 1, our documentation. Our documentation is horrible. Our documentation needs to be better. And number 2 is quality assurance, QA. QA has to happen. So we're gonna talk about those things because documentation, regardless of what, I know right now you guys are focused on a lot of things getting your EMS organization up and running, okay? But the most important thing that you're going to do for your EMS organization moving forward is happening right here, right now, documentation, plain and simple. If you do not have a good documentation program, you do not have a good EMS organization, period. All right, so we're gonna talk about why that is. So I've given you guys a lot of stuff in front of you. Some of it is specific excerpts from protocols, things of that nature. You have a note page in front of you. This is all gonna be interactive. I'm gonna be asking you to help me fill out this page right here. And I hope I left you enough space because when we get to what we document, when we get to number 2,
Who we document?
no, what we document. When we get to what we document, number 3, there's gonna be all kinds of pictures and stuff. It's gonna be cool. You're gonna enjoy it. All right, so let's start off with the first question. What's the first question? Why do we document? Why? Why do we document?
To get reimbursed.
Okay, so billing
Record of the call to cover
is one of them.
butts.
Okay, legal. Okay, everybody's thinking about the negative stuff. Good. All right. Why else?
So the doctors know what care was an issue with them.
Yeah. So let's. It's not just for the doctor, right? It's for the nurse. Okay. It's for the surgeon that's taking the patient in, right? It's for the doctor that's at Harborview that's going to receive this burn patient, right? So it is, and this is really the number 1 reason. There's these other things, but it really is for the patient record, okay? Of which, for the doctor, the nurse, like I said, the surgeon at Harborview, they need this too, right? Okay. 2 more. What's another reason why we do it?
Accountability, but that probably goes into legal.
No, it doesn't. So when you say accountability, what do you mean?
Just one from supplies that we used, actions that were taken, just overall, everything we've done, treatment.
Okay. That is true. We could potentially add a 6th reason to document. When you said accountability, here's what I'm thinking about. QA, quality assurance, okay? Now, what you're referring to, we have some options of how we could categorize that, and if we wanna add a 6th one, we absolutely can. So let's come back to that for just a second, okay? So, but let's get quality assurance in here first, and then what's the 5th one I'm thinking about?
Evidence-based medical practices, that
Which we could put in 2 letters, which is
QI.
QI, right? Okay, so, and then, so there's a number of different ways depending on, so what Sarah is talking about as far as the logistical element of documentation, it really lands in a lot of different buckets. So for example, Jake and Samantha, sorry, your paramedics, are going to have to do some certain skills in order to maintain their certification levels, okay? So they're gonna have to have so many IVs, they're gonna have to have so many innovations and things like that. So when we say legal, we could say, well, the reason why you need to document procedures, not just in the narrative, but also in the medication and procedures section, is because for legal reasons, not tort, not going to court for something you did wrong, but to legally be able to document it, that you can maintain your certification. Does that make sense? Likewise, if you weren't a fire district and you were a private ambulance system that could itemize their billing, you would document those things for billing reasons, okay? So, as far as whether or not, there are people and there are systems out there that try to maintain inventory based on usage, and it is my experience that that does not work well, okay? So, let's just put down here at the bottom, let's just put logistics, okay? I think that's what Sarah's trying to talk about there, and that's not wrong, but depending on the system, that could fall into other buckets. Does that make sense? Okay, so let's go back here and talk about billing. What is it about our documentation that we have to make sure is squared away for billing purposes?
The need for the interventions that we did, and why we did them, and why they were needed.
Okay,
Differentiate BLS versus ALS, ALS to ALS critical care, ALS specialty transport billing.
yeah, so when it comes to billing, the billers have to be able to put what you did in a bucket in order to figure out how they're going to be able to bill that call, all right? So, and we're not gonna get into all of that, okay? But it is critical for you to be able to document the level of care that was provided, even up to, so, EMT, right? So Captain Nichols does an assessment on a patient, okay? You know me, I'm big about rank, even training for all people. So Captain Nichols does an assessment, he's an EMT, okay? Samantha is standing in the back, she's kind of watching what's going on. Everything about this call seems to be BLS, but she's like, you know, let's just do a 12 lead to make sure this isn't ACS. I'm pretty sure this is just a BLS call, but let's make sure this isn't an acute coronary syndrome. Let's do a 12 lead. So now a 12 lead has been done. Can a BLS person do a 12 lead? Absolutely.
Yes.
So does doing a 12 lead make it an ALS call?
No.
No, but I have Samantha standing in the background who is paying attention to what is happening. Then a 12 lead comes out And what is your option as an EMT with that 12 lead?
I have her look at it or I transmit it. to
Or
the
you
hospital.
transmit it, right? So Samantha says, okay, I'm gonna take it, I'm gonna interpret it. So Samantha takes it and she interprets the 12 lead. Okay, have we now done an ALS assessment? We've done a portion of an ALS assessment. From there, Samantha should also say, you know what, I wanna listen to lung sounds. Is lung sounds an ALS assessment? No, but it is when it's done by a paramedic. Okay? So as long as we're very clear on the elements of the assessment that Samantha did, we can now say from a billing perspective that this is actually an ALS call because it meets the ALS assessment rule, and now that call can be billed as ALS, okay? If dispatches the call as a Med 3 ALS, okay, and you send initially a paramedic on that call, it can be billed as ALS, okay? Because a paramedic went to what was dispatched as an ALS call, a paramedic arrived on the scene, even if it turns out to be a hangnail, okay, it can still be billed as ALS. So it's very important that in your documentation, you are taking these things into account because of that very reason right there. Now, you have some things that you have to do, okay? You have to meet those two standards. You have to meet the HIPAA standard, okay? And you have to meet the ICD-10 standard. What is ICD-10?
It's the Medicare standard for billing.
It is the Medicare standard for billing, which also sets the standard for codes for every medication, every diagnosis, every field impression of a paramedic or EMT or whatever. So when you guys are charting, we are going to, whoever is your QA officer, big ugly guy in the back of the room there, he should be making sure that number one, he is your HIPAA control officer, I'm guessing now too, right? Right? So that means he is controlling your PHI. My medics hate me because I walk into a station unannounced, they're out of the house, and I see PHI laying around. I hide it in the back, I don't hide it, I put it in the back of a drawer somewhere, secure it, and I send them an email. You will find the documentation that you left laying out about so-and-so in a back drawer, wherever, right? It's not too crazy. But PHI, you guys, you have no idea. So, Jake mentioned ICD-10, and he mentioned Medicare, okay? If Medicare suspects fraud, who does the investigation? Anyone know?
I'm guessing some kind of insurance company?
No,
that they-
the FBI. FBI investigates all HIPAA and suspected fraudulent billing, okay? It's serious, okay? And if you fraudulently bill, so for example, if one of our billers submits a bill for a patient that it was not determined to be medically necessary for them to go by ambulance, okay, and we bill it anyway, we could be charged up to $11,000 for that one fraudulent document, plus the cost of the amount of the transport plus the mileage for every single one of them. Yeah.
I have a quick question. Will the ABN form just allow us to bill them directly, or will that kind of help with the liability? Or are you saying?
So ABN forms only work for Medicare patients, okay? And yes, it will help. Because in the ABN, basically what you're doing is you're saying, okay, we don't think this meets the standard for medical necessity to be transported. So, but you want to be transported, okay, we're gonna transport you. You just need to know, and I didn't bring a copy of the ABN form, we probably should do that. You need to know that if Medicare rejects this, you could be billed the full amount of the cost of the transport, okay? So different, I'm not gonna get into all that billing stuff, cause different billers handle that a different way, but just know that there is mechanisms for that. That does not exist for Medicaid, and it does not exist for standard insurance. So it's only about 30% of your patients, at least for us, it's about 30% of our patients that are Medicare, so, yeah.
So, what's the legality of, I look at a guy and say, there's nothing wrong with you, I don't need to transfer you.
Why did he call 911?
Yeah,
Why did he call 911?
because he wants to go.
For
I've had
what
this
reason?
happen.
For what reason?
He had toothache.
Okay. Please get on the cot, sir, let's go to the hospital.
Okay.
Okay, have you watched Dr. Hodges' recent lecture on refusals?
No, I haven't.
Okay, go on to Target Solutions, on the homepage of Target Solutions, there's a video, it says endocrine on it, but it's the MPD meeting from last month. Click on it, go to the 20th minute, and listen to his 25-minute spiel on refusals. He has a complaint, take him to the hospital, okay? Where people get hung up is that it is not your job to establish whether medical necessity exists or not, okay? And I'll be the first to admit that I have steered our medics wrong a little bit in this, because I want medics to be able to articulate and identify medical necessity, but in the end of the day, it is a pencil pusher in Washington that truly determines whether or not medical necessity existed or not. Your job is to chart the call as best you can so that they, a pencil pusher in Washington DC, can establish whether or not medical necessity exists or not. Does she need all this stuff? Okay, so let's just get that very clear right now. If somebody calls 911, as Dr. Hodges said in January, the expectation is that person wants you to take them to the hospital, okay? So I don't care if it's a toothache, an earache, a hangnail. If they have a complaint, thank you, sir, get on my cot, let's go to the hospital, okay? All right, so what else do we want to make sure we cover with billing? All right. We will come back to these two standards a lot, okay? So just kind of be aware of those, all right? Okay, let's talk about legal.
I do have a quick question with billing,
Yes.
if you're done discussing
Yep.
that part. No, we were told not to fill out the billing on the actual report. Is that still accurate?
I can't speak for your agency.
Or,
I can't speak for your agency.
We will be-
My agency does not fill out the billing section. My guys don't do that. That's what the billing department does. We have very few, we have a couple elements of the billing section that we do, but majority of it we don't.
And we will be getting into that. I've been talking with April. The main one is resident, non-resident.
Huh? Yeah, please, yeah.
So,
I want you to be safe, Bob. Okay, so you'll address that.
yeah,
in turn.
that's
Okay.
agency.
I'm not here to
specific.
set your agency policy, I'm here to talk about things generally. All right, legal. First legal thing you gotta worry about is the WACs and the RCWs, okay? And those drive a lot of what we talk about in the protocols, what you may talk about at an agency level, all right? And a piece of that is going to be your SOAP, okay? Now, the WAC does not say that you have to write a SOAP. That is driven by Dr. Hodges. But the WAC does say that Dr. Hodges has the authority to tell you you're going to write a SOAP, okay? All right? All right. The patient record. What are we looking for in the patient record?
Name, date of birth, phone number, address.
So we're gonna have PHI, private health information, right? You're gonna have vital signs, okay? You're gonna have to have their chief complaint, all right? You're gonna have to have the assessment of where they were when you arrived, so arrival, okay? You're gonna have to have your actions and the result of those actions. And this is probably the number one thing missed by EMS providers. We all love to write what we did, we don't like to write what happened based on what we did. If I shock someone with an AED, what happened? this is the other thing that we're not very good at, is why we did something. So ICD-10 says that I have to document why I did things. So this is fairly straightforward for let's talk about EMTs, okay? You guys can now give aspirin, right? Okay. Why'd you give it? Now, you've written this beautiful subjective of a patient who called 911 complaining of crushing chest pain, 10 out of 10. Okay, you arrive, he's sitting bolt upright in the chair, clutching his chest, he's pale, he's gray, he's diaphoretic. You've written all that wonderful stuff. You've laid out these beautiful vital signs, okay? And then you write your assessment, patient having chest pain secondary to an MI. Wonderful, okay? And then you write your chronological plan, that you did ABC, scene safety, you got a history, you did an exam, and you administered 324 milligrams of aspirin PO. Okay? Why? Now you say, duh, because he's having an MI. Here's the problem. Where's this person sitting?
In a cubicle.
In a cubicle in Washington, D.C. And all she knows is that when she reads an EMS chart, if the EMS chart doesn't say specifically why something is done, she can reject it. And she can accuse your department of fraudulently billing that call. Okay? So we write what? 324 milligrams ASAPO
Per protocol.
Due to chest pain.
for, that would be the better thing. Per protocol would be a generic
Standard of care, right?
whatever. But it's better to write, I started an IV for fluids and medications. I gave aspirin for chest pain. I gave nitro for chest pain. I gave fentanyl for chest pain and anxiety, okay? Write why you gave the drugs or did the procedures that you did. Shocked patient with an AED. Why? You could write, because the AED told me to, okay? But why? Because the patient was in cardiac arrest, okay? So we should be doing those things. Then, what happened after you did it?
Changes that happened or changes
Yeah,
that
was there
didn't
any
happen?
change? No change. Or patient's chest pain reduced to 5 out of 10, you know, or what have you. Does that make sense?
Continued CPR.
Or continued CPR.
Hopefully they
Right.
don't wake up and say.
Yeah, right, exactly. Okay, all right. So, does that make sense? So your patient record, and we capture all of this, including transport decision, okay, and pass off, okay? Your pass off at the ER should include the room and to who, at a minimum.
When you say room, do you mean like the number?
I transported patient code 3 to Trios, ER, okay? Patient delivered to room 7, RN Jones, or Dr. Thomas, or whoever you handed the patient off to and gave report to, that should be documented, okay? Actually, for ICD-10, it must be documented. Okay, now, this is a 10,000 foot view. We're gonna get much more, hopefully, into the specificity of all of this as we move here, okay? All right, let's talk real quick about QA and QI, okay? QA is about specificity, okay? And by specificity, I mean specificity of that patient's care and your, I'm gonna call it your knowledge, skills, and abilities, your KSAs, okay? I just reviewed a chart about 20 minutes before walking in here. I have an individual right now that I'm reviewing all of his charts. I read this chart, of which he was very thorough in his chart. In fact, to his demise, he was so thorough in this chart that he painted a very clear picture to me of an acute exacerbation of heart failure, okay? But he didn't get it. He didn't get it. He did not get that that is what he was looking at. Now, was it a CHFer with a blood pressure of 220 over 110 and frothing at the gills? No. It was a much milder exacerbation, but he still didn't get it. Clearly, by his diagnosis, he did not get it, okay? So him and I are gonna have a conversation about recognizing acute heart failure, okay? We're gonna have a conversation about his skills, okay? Because had he recognized it, there's some things that he should have made sure were happening, okay? So QA is specific to the patient and the EMT or paramedic, whatever it is, okay? It is specific to them, all right? And it is a case-by-case review, all right? Quality assurance is different, okay? Quality assurance, I guess if you wanted to use a word, you could call it global, okay? So Dr. Hodges has an expectation that every EMS chart in Benton and Franklin County is reviewed, okay? And we actually have a generic run review in ImageTrend for every single chart. And the idea behind it is that we are at least globally looking at it and going, okay, yeah, hey, it looks like the basic elements are there. Then we can get specific and we can say, okay, we are going to review every chest pain call. And currently, the things that we are looking for in QI is when a patient is having an ACS, are we getting a 12 lead within 10 minutes of arrival on scene? Are we getting a 12 lead before we initiate transport? Are we administering aspirin to every ACS patient? And if we aren't, are we identifying why we aren't giving them aspirin? And I'm forgetting what the fourth thing is that we're assessing in there. There's one more thing. But anyway, so what this is going to, when we get a boatload of data here, we are going to be able to say globally, okay, across Benton and Franklin County, and we will be able to put it in buckets too by agencies if we want to. But we're gonna be able to say, I would venture to guess right now at Kennewick, probably right around 98% of the time, we get a 12 lead before transport and within 10 minutes. Okay? You can only make statements like that when you are assessing for those kinds of things. Now, if we had another QI form or evaluation that was looking at C-collars, okay? Are we putting C-collars on appropriately? We can frame the quality improvement evaluation to say, it could say a lot of things. It could say patients aren't getting C-collars like they should. It could say we're inappropriately applying the T4 protocol or not applying the T4 protocol 5 out of 10 times, you know, something like that. But that's what that's for. So that Dr. Hodges or whoever can stand up in front of a group of people and say, hey, we are doing really good with 12 leads, and we're doing really good with aspirin, but we are doing horrible with the T4 protocol and assessing people for inclusion to having a C-collar or whatever, okay? And then we can say, okay, why is that? I'll give you a real life example. And this hasn't happened through the QI process per se, but we had a stretch over a period of about 6 months of paramedics regionally inappropriately giving diltiazem, okay? Putting a number of people in the ICU for inappropriately giving diltiazem, okay? We're like, why is this happening, right? Okay, well, as we dug into it, we saw at the end of the day there was 2 failures. Number 1 was education. Number 2 was this book right here, okay? It was not specific to a particular vital sign that needed to be assessed and then attributed to whether or not the medic should be giving diltiazem or not. And we've fixed that, and we're not seeing that problem anymore. We're starting to see a different problem, semi-quasi-related, but again, okay, that's training, right? So QA helps me train the individual. QI helps me train the region. Does that make sense? So your documentation, even at the agency level, helps you as an individual, and it helps you as an organization, and it helps all of us as a region. Does that make sense? Okay, and then we touched just briefly on logistics there, but that's where we can know, hey, you know, according to our documentation, we only started 100 IVs last month. But yet, we've had to order 300 IV catheters. So either these two knuckleheads don't know how to start an IV, okay, or we're wasting a lot of IV catheters, or we're ordering more than we need to. I mean, there's a number of options here. What do you think? Is it you two? Are you the problem?
I learned from you, so it's possible.
A long time ago, though. I don't know what you've done for the last 10 years. All right. Okay. Does that all make sense? Okay. Questions before I go on? Okay. Okay, so now, what are we gonna talk about? We're gonna talk about who we document. All right? Who do we document? Who do we document?
Every patient we contact.
Everybody touch.
Maybe. So I heard patients, okay?
Ourselves?
What constitutes a patient? That is the question.
Somebody with a chief complaint.
Negative.
Who calls for our services?
Well, let's write it down. Let's write it down. Okay, so Jake says somebody with a chief complaint, okay?
Someone that you
Maybe that
at
we
least
can-
at minimum provide an assessment to.
Okay. Patients who get assessed, okay? I will say that is 50% of what makes a patient, okay? What is the other half?
Patient involved at our scene. Even if we don't document them, we have to say that out of patient, this person refused, that we were talking about. the other
But
day.
were they a patient?
Yes, because they call.
Because I assessed to see that they didn't need.
No.
If you take
No.
interventions on.
We are identifying what constitutes a patient. That's what we are constituting here. What makes a patient? So 50% of it is a patient who receives an assessment from you. What is the other half?
The people who call
Interventions.
for-
No. All right, just tell us. Patients that you take PHI from. The moment you take private health information from them, be it, and I'm gonna exclude their name, okay? But when you start taking dates of birth, okay, social security numbers, okay, addresses, phone numbers, things of that nature, one could argue you have entered into a patient-provider relationship, okay? So that's why, Samantha and I were having a conversation the other day, and this too, this is a little bit nebulous here. I'm gonna put an asterisk here by this, because this could be agency-driven, the PHI piece. So for example, in Benton 4, okay, if you call and you have a complaint and they initiate any kind of assessment, that is the bar. You are a patient, okay? And that's it, okay? They take PHI on just about everybody, even a person who's involved in an accident but who says they don't have a complaint, they take their PHI and they document that they had no complaint. They take down their PHI and they have them sign a refusal. Now that's Benton 4's policy. I'm not saying it's a good policy, I'm not saying it's a bad policy, there's pros and cons on both sides of that argument. Okay. For Kennewick, it is, if you assess the patient and you took PHI, it's a patient, you're writing a full PCR, okay? So for us, this equals full PCR, okay? So, what Samantha and I were talking about the other day is you arrive on a motor vehicle accident at the corner of Oak and 27th, okay? And you have a patient that you're gonna transport to the hospital, but then there was a passenger in the passenger seat and they have no complaints, okay? Do you get a refusal from that patient? Because they have no complaints, they don't wanna go to the hospital. What is that? Is that a patient? Huh?
No.
No?
They didn't complain about it, they didn't want.
How
What's
do
your
you-
policy? What's
how-
your policy?
So how do you know that they don't have any complaints because you asked them the question?
Yes.
So if you ask them a question, isn't that the beginning of an assessment?
I think it depends on the nature of the car. I mean, did the
So,
driver die?
that is, no, I don't think it is.
Okay.
I don't think it is. An assessment is, in order for me to initiate an assessment with you legally, I have to say, hello, sir, my name's Eric, I'm a paramedic, how are you today?
Nice to meet you.
Okay, do you have any complaints?
No? Okay, yes.
What's hurting?
My arm hurts.
Your arm hurts. Would you mind if I performed an assessment on your arm?
Sure.
That.
Okay.
Now I'm starting an assessment.
Okay.
Because in order for me to do something, I have to get what?
Permission.
Consent. I have to get consent, right? So we're not, remember my other favorite topic, medical legal, which we're
Yeah.
not getting into, okay? I have to get consent in order to initiate. Now, I introduce myself as a paramedic, yada, 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 and now we've entered into a patient relationship. If a police officer walks up to me and says, hey, you got two people involved in this accident, one of them clearly needs to go to the hospital, she's in the driver's seat, yada, yada, yada. There's another person, the person that was the passenger, they're standing over there by the corner of stop or walk and don't walk, and they don't have any complaints, okay? So now I can walk over there and go, hello, sir, I understand you were the passenger? Yeah. You're okay, you have no complaints? No, I don't have any complaints. Okay, and now I know, I've got a 70-year-old male here, kind of old Jake, okay, who had no complaints, and I will chart that in my fire report. 70-year-old male, passenger in the blue vehicle with no complaints. So now, I've charted that, he is not a patient. I can put that in my narrative of my fire report, so if later he decides, oh, my neck hurts and I'm gonna sue them, they can read right there in my chart. 70-year-old male that was the passenger in the blue car had no complaints. He was asked, we charted it, and we've covered ourselves.
And no refusal necessary because.
And no refusal necessary because he didn't have a complaint. Make sense? Yeah.
I have a legal question. Can I ask?
Please.
Okay, so at my B job, we get a lot of subpoenas for everybody involved in the accident. Lots of insurance do that. Are we gonna be giving them a fire report with 10 different people on it, even though their PHI technically is not there? And, cause how do they pull patient records when their name's not attached to the PCR? And so what if driver A was injured, transported, the insurance company with everybody in the rig?
So when they're in discovery, they have to ask for specific information. Or they can blanket it, and they can say, give us all documentation, which is typically what they do. Give us all documentation related to this incident that so-and-so was involved in, okay? So one could argue, well, we don't know who so-and-so is because we don't have a patient record for him. But what was the event? Oh, here was the event, here you go. And we will redact all of our names out of it, okay? And then they can read the chart, okay? I've done a lot of expert witness testimony, and those cases don't go very far because they don't have much to stand on, so, yeah. Okay, other questions? All right, so that is who our patients are. Does that make sense?
Yeah.
Okay. Okay, now we are going to talk about who, we just talked about who. Now we're gonna talk about, what's the third one?
What?
What? Sorry, guys, I woke up at, I get up every morning at 4:45, and, this morning at about 5:30, I said, you know, I should probably prepare for this class, and this is what came to me. So, what we document, this is gonna be fun, and I'm gonna have to get my, this is a whole chart here, so this is gonna be fun to write out. All right, so what we document. All right. So, first of all, in a blanket statement, we document all interaction with patient. And that is a very broad statement, okay? Let's be clear about that, okay? All right. So, what is your first interaction with a patient?
Hi, my name is,
Negative. Negative.
Dispatch.
911.
Thank you. Okay? So the very first thing is dispatch, right? Okay? ICD-10 requires you to document what you were dispatched to, and Hodges, I still can't get him to understand it. So you will see things in a Kennewick chart that are not written in your protocols here. Okay, you have a protocol here for documentation, G7. It tells you what you have to document. It does not tell you in there that you need to document that you were dispatched to a 57-year-old male complaining of chest pain, Med 3. Now there's a reason why Kennewick does Med 3. Why? Anyone want to guess?
Billing.
Billing. Because a Med 3 is an ALS. So I can automatically bill that call, ALS, provided I have a paramedic that goes and a paramedic that does an assessment, okay?
So the CADS class, Certified Ambulance Documentation class, the lawyer, like they came up with the whole report writing system, and it's the DRAT system, and they specifically stated that dispatch, like the first thing you should put is dispatch, and what you were dispatched to, and that was the specific reason why.
Yeah, exactly.
To me, I feel like that falls under call type, and it's just us that needs to elaborate on it. Unit medic 25 responded to a 57-year-old female, dispatch code 3, whatever, code 3. It's just
Yeah.
knowing that when you read it.
Yeah, and so all I'm trying to do is help you navigate that a little bit easier for here, okay? All right, okay, so here we're gonna have our 57-year-old, and I'm gonna do abbreviations just to save space here. 57-year-old male complaining of chest pain and shortness of breath. We're gonna come back to that in a minute. Actually, in just a minute, we're gonna come back to it, okay? Med 3, okay? All right, so now I've got what I was dispatched to, all right? Now, as we go through this class, you guys are gonna see me write abbreviations, okay? So in your handouts there, you guys have some abbreviations, correct? Okay, are all of my abbreviations here on the list?
Not the symbol.
Huh? The symbol is not, but this is a standard medical abbreviation, okay? That we can't really do anymore now that we digitally write everything. Back in the day when we hand wrote reports, my goal was to write my entire narrative in abbreviations because it saved me a lot of time and I could write a lot of information, okay? Is everything in there? Now, why did I come back to SOB? Why did I come back to SOB? Not just because it's in there.
Because it could be an ALS level for billing.
No. Because when I am sitting in the court, or I am sitting in the deposition, and the lawyer is grilling me about what I did, why I did it, and all of that, and he asks me this question: Rob, do you like this patient? Do you like this individual that you were treating as a person?
I don't know the individual, so I can't make an assessment.
Well, why did you call him an SOB?
Shortness of breath.
How do I know that's shortness of breath? Alls I see here is that you called this individual an SOB. To which you reply,
That is standardized medical terminology that you can find.
and I have it where?
In our
In my protocols. So everyone, use the abbreviations that are in your protocols. Do not make up shit, okay? I got some paramedics that I gotta just drub into their heads. They just make stuff up, I swear. GLF is not a standard medical abbreviation. It is a paramedic EMS abbreviation that has been made up. Anybody know what it is? GLF?
No.
ground level fall. See, nobody knows what it is, but yet I see it all the frickin' time, okay? You're just typing ground level fall, okay? All right, so make sure your abbreviations are legit, okay? All right, what's something else that we document?
Following the order on the soap you're laying out right now,
The what?
following your order.
Well, you guys don't have anything on that, this is all just open. So the next thing we're gonna talk about, we're gonna document is vital signs, okay? All right, what vital signs?
Initial vital signs,
Okay, initial vital signs?
Trending vital signs.
changes in them.
Ooh, good, all right, so when we come to vital signs, the first thing we need to do is our manual vital signs, all right? Or should I say versus digital vital signs, okay? All right, and truly, we should identify whether they were taken manually or digitally, okay, by the machine or by the man, right? Or the woman, sorry, no, I'm not trying to sound chauvinist there, okay? All right, so first of all, we should be identifying that. Now, they threatened us that it was coming, but it still hasn't happened. It was supposed to happen in October of 2019, but there was supposed to be a new Medicare law that came out that said if all vital signs that were taken by a machine have to be digitally transferred into the PCR. Okay, now we do that, we all meet that standard here now, that we have Zols and we have ImageTrend, but you're also supposed to document where those came from. All right,
So
then,
I have a question real quick.
go ahead.
So, one of the menu options when we are documenting the vital signs in the vital signs tab of ImageTrend, it asks you, was this taken manually or was it taken by automation? So do we have to document it both there as well as in our
As
narrative?
long as it's in the PCR.
Okay,
As long as it's in the PCR.
Okay.
So Hodges was, until he saw what ImageTrend could do, he was kind of being a little about that.
Okay.
And we're like, Doc, it's all right here.
Yeah.
What do you wanna see? So what we did was the vital signs that originally were at the very bottom of the chart, we just moved them right up underneath the narrative. So now he can just very easily look down and see them. We're gonna talk more about that piece of vital signs here in just a second. So as Jake said, I need to see my initial vital signs. As Samantha said, I need to see my trend of vital signs, and I need to see my
Changes.
okay, so I'm gonna include changes in here, obviously, because that's part of the trend, but I need to see my last vital signs, okay? All right, I have to have those, which is why the Medicare rule says on a any patient transport, you must have 2 sets of vital signs. Okay, that's why, because you had to have an initial, you had to have a last. If you were only with the patient 15 minutes, you can't really have a trend in 15 minutes, can you? Okay, on a critical patient, could I have a trend in 15 minutes?
Yeah.
Rankin A, yeah, absolutely, right? So those are the things that you have to have with your vital signs, okay? All right. I'm gonna flip-flop those. Okay, the next thing you need to have is your assessment. Okay? All right, and what comprises the assessment?
Do you want like
Let's
the
not make it
head
any
to toe?
harder than it is. It's super simple. It's one of two words.
Initial one.
Yeah. I'm gonna make it easier than that, because I want you to break it down to the end, right? Chart, right? So your assessment, you have a subjective assessment, and you have an objective assessment. Okay? What is within the subjective assessment?
Everything you were told.
Told, and one other thing,
See.
the scene, right? Okay? So if I'm responding to a 21-year-old male with neck pain after a motor vehicle accident, okay? I was told that. That's part of my subjective. I can't see that he is having neck pain, okay? I can see some things that go, I bet that hurts, okay? But that's not subjective, okay? So things that I'm told, and then I can say, 21-year-old male was restrained driver in head-on motor vehicle collision between a Honda Accord and an F-450, okay? Patient was in the Honda, however you wanna write that in a way that flows a little smoother than the way that I just said it, okay? And 1 foot of intrusion into the, engine compartment, okay? At low speeds, clearly, okay? All right, so that is your scene, that is your subjective. What else comes into my subjective?
Patient history.
Right, so previous medical history,
Your sample.
yeah, your sample, there you go, let's just do that, let's just write sample, okay? And I like sampled, okay? What's S?
Signs and symptoms.
Signs and symptoms.
Allergies, medications.
Okay, let's hear the EMTs now. Past medical history,
Pastoral.
events leading up to the call for 911,
Incident.
okay, and
Denied.
denied.
I think D is new, so.
The D is what they denied. These are your pertinent negatives, okay? So if my 57-year-old male complaining of chest pain and shortness of breath calls 911, that is what? That's my signs and symptoms, okay? Now okay. Previous medical history, I can ask him about previous episodes of chest pain, heart attacks, whatever, right? What were you doing when this happened? I was sitting here watching whatever, Jeopardy, okay? Now, what kind of questions do you wanna ask him about his chest pain and shortness of breath, not the paramedics, the EMTs?
Quality.
Okay, you wanna ask about the
Stabbing,
quality.
sharpening.
Is it sharp, is it crushing, okay, what else?
Scale,
Huh?
scale, like.
Scale, 1 to 10, right, very
Is it
good.
moving, is it radiating out?
Is it radiating? Okay, he says, no, it is not radiating to my jaw or neck or left arm.
Is that a pertinent negative?
That is a pertinent negative,
Okay,
okay?
it's
All
still
right.
good information to have, cause it lets you lead down
Heck
that
yeah.
path, but it's,
Okay, so now what else do I wanna know? What other pertinent negatives do I potentially wanna know about this? Sir, are you experiencing any nausea? No, I'm not. Okay, so, no radiating pain, okay? No nausea or vomiting, okay? What else?
things that help or don't help.
Yeah, palliation provocation, right? Have you been able to do anything to make this feel better? No. It frickin' hurts. I feel like a dump truck's on my chest. Okay, all right. So I can say no, is that palliation or provocation? No palliation. Okay, meaning nothing makes it better. Okay, does that make sense? Those are all pertinent negatives. Those are the D of your sampled. Okay, all right. So that's your subjective. All right, what's my objective?
Things you see.
Yeah.
Huh?
Things you see.
Yeah, what do I see? What do I see? The number one, most important ICD-10, oh, I got rid of our ICD-10. ICD-10 requirement in all charts. Has to be documented, period, end of story, no questions asked, every patient. Nope,
Physician,
what?
physician found, like.
Yes, exactly. You have to identify their position when you first approach them. And that's important. 21-year-old male complaining of neck, back, chest, abdomen, leg, head, eyeball, left ear pain, okay? Saying worst pain he's ever had in his life, all right? Saying he's going to die while he walks around the scene, checking on his tire and his cell phone and calling 10 people on the phone while you're trying to do an assessment, okay? What was their position on arrival? It could be as simple as it was sitting. It could be they were in tripod, okay? They're in tripod position, and I'm going on a difficulty breathing. What's that tell you?
They're having problems.
They're having problems, okay? So ICD-10 standard says you will document the position of the patient upon your first contact with the patient. Always. So my charts always start the same. On arrival, and Hodges always laughs at on arrival. He's like, well, no, it's on arrival. How's, because ICD-10 requires me to state the position of the patient on my arrival, not 5 minutes after I got there. Okay, so on arrival, patient sitting bolt upright on chair in kitchen. Okay, all right. One more thing, let me go back here real quick regarding scene. ICD-10 also requires you to state with specificity where they were at and what kind of, for example, a roadway, like a motor vehicle accident. Okay, motor vehicle accident occurred on a 2-lane residential street with a 25-mile-an-hour speed limit. Patient was located sitting on the curb next to the car after self-extricating, now complaining of left knee pain. Okay? That is the kind of specificity that ICD-10 expects in their charts. Okay? That makes sense? So what does that begin to tell you? Okay, I've got a patient who's complaining of left knee pain after a motor vehicle accident and a residential that's probably a 25-mile-an-hour posted speed limit. And you could even get that specific and say, with 25-mile-an-hour posted speed limit, okay, involved in a motor vehicle accident traveling at 45 miles an hour, okay, all right, what are we starting to paint our picture for here? Is this as much for ICD-10 or for legal?
Legal.
Legal, right? Legal reasons for documentation. Okay, so we're gonna paint a picture of their position on arrival. What else?
Patient is Lerton Oriented 10 score with a GCS of 15.
Yeah, so we're gonna talk about their LOC, okay? And then from here, after LOC, you can go a couple of different ways. Your protocols say you can go body systems, okay? Or you can go head to toe. All right? Oh, shoot. I forgot one thing. Sorry guys, I'm bouncing around here. Please forgive me. All right. Bouncing back up here to vital signs. Okay, paramedics. There are 2 standards here in Benton and Franklin County. Paramedics, Dr. Hodges expects, and why am I looking at them? I'm looking at you two. Okay, he expects you to write an interpretation of the vital signs. Okay, patient was, or you could start vital signs, positive orthostatic, off on blood pressure and heart rate, okay? Or off on blood pressure if it's just one or whatever, right? So you're gonna interpret the vital signs. For EMTs, he expects a blood pressure, a heart rate, a respiratory rate, an SaO2, and then from there, depending on what else is appropriate, a blood glucose, and that would be basically it for you guys. For you guys, paramedics, in addition to your interpretation, you should have a blood glucose, an ECG, which means what? A 12 lead. With what? 3 points of data, okay? Right? You got that? You guys have been through all that, you know that, right? 3 points of data. End-tidal CO2, okay? Anything else? Okay, that's pretty much it. So that is the expectation for vital signs, all right?
So when you say expectation, that means when warranted, because a 12 lead isn't always warranted for every patient.
True, when warranted.
Okay. There's different.
And you better understand what Dr. Hodges' expectations of when warranted is. So for example, this chart that I talked about that I'll be reviewing with this paramedic, yeah, there should have been 12 lead, no 12 lead, not meeting the expectation, right? So, any patient with altered level of consciousness, blood sugar, right? We all know that. So, blood sugars, right, when appropriate, okay. All right, anything else? I'm not going in all the details on this because we only got 2 hours here, but your body system versus head to toe, okay. Now, let me be clear. Okay. So, I've been in this world a long time. And I've read a lot of documentation, okay? And I know when I am reading a chart that EMS provider has no freaking clue what to write, okay? All right? So, I'll give you an example, all right? And this, I could really go down the rabbit trail here, so If I seem to be going too far down the rabbit trail, please pull me back, all right? You're writing a chart, okay? You've responded to Findlay High School, all right? For a 14-year-old female, all right? Complaining of difficulty breathing, okay? Top 3 things in your head.
Anxiety, asthma,
Come on, show off.
sorry.
What else?
Allergic reaction.
Allergic, yeah, okay, good. We have three potential diagnoses before we even got on the scene. Excellent. All right, so you get on the scene and what do?
Assessment.
You initiate your assessment. You identify what position was she sitting in. Oh, she was sitting in the corner of the female bathroom, of the girls' bathroom, with her knees drawn up to her chest, crying. Okay? What are you thinking?
Anxiety.
Anxiety. Of course you are. Okay? She's tachypnic, which means what? Breathing fast. Okay? You ask her if you can take vital signs. She says yes. You start to take your vital signs. You get a blood pressure. You get a heart rate. You find out her respiratory rate's 36. You have a couple of paramedics with you here, so they decide to do an end-tidal CO2. Her end-tidal CO2 is 18. What's that tell you?
Anxiety,
Anxiety. Okay? You begin to tell her to do what? Where's my EMTs? Relax. How do you tell her to breathe?
In through your nose, out there.
In through your nose, out through your mouth. Everybody chill out. Let's help this young lady chill out. Okay, this is no big deal. It's just a little anxiety attack. Okay, so, and I want to make this clear. Sorry, gal. Sorry, ladies. You 3 are not on the scene. Okay, this is Jake, Captain Nichols, Lieutenant Rob. Someday it's gonna be Lieutenant Dan, I just can't help myself.
I'll take it.
Okay, and what's your name?
Bernie?
Bernie, okay? You guys are here helping this young lady out, okay? You calm her down, all right? What other vital signs do you want? Anything? SaO2?
Yeah.
SaO2 is 100%, okay? What else do you wanna know?
lung
Center
sounds,
period.
Lung sounds, okay? Lung sounds are clear and equal, okay?
Why is she stressed out in the bathroom?
My boyfriend left me.
Okay,
Okay, all right,
sorry, I think pregnant automatic.
okay. Is that a legitimate question for her to be asked?
Yes.
Absolutely. How do you ask that question? Professionally?
Professionally, have you, are you pregnant or have you missed your period or,
When's
and I
your
try
last
to do
When
it
was-
off.
When was your last menstrual
Yeah.
cycle or period? Okay.
Probably right now.
Is there any chance that you could be pregnant right now?
Yeah.
Okay, those are good legitimate questions. Okay, tell me about your physical assessment of this young lady. What's that look like? Are you guys EMTs? No, the ladies still aren't there.
Oh,
You guys aren't EMTs? You are? Okay, what's your physical assessment look like, sir? What's your name?
Right.
Brian? Okay, nice to meet you.
Head to toe. Like
Head to toe? What? So what's your head to toe look like?
No findings.
Oh,
no finding.
No, that's not what I mean. I want you to tell me everything you're gonna do for this head to toe.
All of a sudden, we're kind of narrowing it down to anxiety to see if there's any other indicators for injury.
So she's just, so what, tell me what that looks like. I know I'm putting you on the spot, but,
You were there with us, remember the gal in Findlay High School that we had?
so you're.
So are you getting at that you more likely gonna do a body system as opposed to a head to toe on this one? Cause there's no reason to palpate the head
Yeah.
and the neck and the arm.
Yeah, is there a legitimate reason to do those things?
No.
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 No. Okay. So we're gonna talk about a body systems evaluation, right? What body systems?
Well, since we-
Respiratory primarily, since
Yeah.
that's.
Okay, so Jake said, let's listen to lung sounds, we did that, what else?
Palpate the abdomen, maybe?
So you can see if she has any self-harming,
Okay.
you said her heart rate was 36, but she picked her up
No,
around-
I said her respiratory rate was 36.
Okay, that's why I was like listening the whole time.
No, her heart rate's no,
Yeah.
a little elevated, about
Yeah,
100,
you're going somewhere else.
okay? So here's what I'm getting at, okay? You do not have to raise your hands here, okay? But who here, this is rhetorical, has evaluated this patient, and then they get back to the station to write their chart. They don't give it any mind what kind of evaluation they actually did. and they start to write a head to toe. And they write, hint, atraumatic. Well, that's good because our assessment was an anxiety problem. So what do we care if there was a trauma? Then we write neck. I hate it when medics do this. Trachea midline. I freaking hope so. I wasn't thinking she had multi-system trauma with a tension pneumothorax. Okay, I thought we were looking at an anxiety problem. And then we work our way down through the chest and the abdomen, and we write pelvis, and we write intact, okay? Then we write extremities, okay? And we write whatever we, oh, no self-harm, no indicators of self-harm. That's actually a good assessment. I actually like that. That's good, okay? Everyone's fat, dumb, and happy. You're back at the house, you've written your chart, you're eating your pizza and whatever for dinner, okay? Now she's home, and the attention that she was receiving has worn off, and she decides, I need more attention. Jake's heard this before. I've used this for a decade or longer. And she starts to cry. And mom asks her what's going on, what's wrong. And she says, that EMS provider that has the flat top from the 70s, he touched me. Okay? And they read your chart, and in your chart, you wrote pelvis intact. How do you know? Did you rock the pelvis? Yes, ma'am.
I'm guilty.
We've all done it.
So the way I always viewed it was she was able to stand and walk.
Then that is fine. But when you write something like intact, okay, what does that mean?
It means you actually palpate.
It means you actually palpated the pelvis. You rocked it, you touched it, okay? Was there any reason for this young lady for you to assess her pelvis? Period. No. A better way is, let's just leave this out of it. The only time I write pelvis is elderly females who fall and I'm ruling out a fractured hip, okay, and pelvis goes with that. Multi-system trauma, significant. Do you know how much? Where's my football fans in here? Okay, what happened to Chris Carson this football season? Fractured pelvis. Do you know how much force it takes to fracture a pelvis? Which makes you go, holy crap, how do you fracture a pelvis on a simple running play in which you get side blocked? That's a lot of frickin' force, especially when these guys, their bone density is off the charts, right? It takes a lot of force. So be careful here. Write for purpose, okay? And if you don't have a purpose to write it, don't write it. If you didn't do it, don't write it. The worst mistake you can make in a chart is to write something you didn't do, all right? Sure, we've all been there. I've been there 100 times, you guys. How long have I been in EMS? Longer than most of you have been alive, all right? I have not assessed things that I wished I'd assessed on patients. And gosh, dang it. I got so busy with CHF patient, I never listened to her lung sounds. I'm gonna look really frickin' stupid to Dr. Hodges. Oh, well, I bet I won't forget that next time, no matter how busy I get managing this really sick patient. You know, despite the fact that I could hear the frothing at the gills, okay? It happens, okay. How will we deal with that? QA. QA is not disciplinary, QA is not punitive, QA is about making us better, and we will find that out when we see a legitimately well-written chart. Does that make sense? Okay, any questions about that? I gotta pick up my pace here. All right. All right, all right, now, where'd you guys go to or EMT school? CBC? Bernie?
San Antonio.
San Antonio?
Yeah, I got mine through the military.
Oh. What branch?
Army.
Thank you for say what I wanna say. But you can say what you wanna say about me, Air Force, okay? Alright. Okay.
That just opens a whole new.
Okay. Here's the question, Bernie. Do you as an EMS provider diagnose patients?
No.
Incorrect. I guarantee you were trained that, weren't you? You were told you do not diagnose.
I was gonna say, we were told the exact same thing, we do not diagnose, we treat.
Differential.
You, every single one of you who has an EMS patch on your shoulder, diagnose. You have to diagnose. It is impossible to treat a patient unless you diagnose, okay? So, we diagnose. With me on the other, okay? Period, okay? If you wanna call it a differential diagnosis, I don't care. You wanna call it a field impression, okay, fine, call it a field impression. It is not a rule out, okay? You use that, Dr. Hodges will eat you for lunch, okay? You guys, he's got way louder bark than bite, don't worry about it, okay? But let's just be clear, we diagnose, and because we diagnose, we will write the chart indicative of a diagnosis, okay? And he makes this big deal about, that is not a billable assessment, okay, or diagnosis, okay? But, you do diagnose. So, I've got a 57-year-old male complaining of chest pain and shortness of breath, right? Are you still on that chart, right? We've left the 14-year-old alone, okay, which is fine, all right? We've taken our vital signs, okay? Sam or Jake showed up and they did a 12 lead, all right? And this patient is having an ST elevation MI, okay? All right, how do we write that?
STEMI?
We could get real simple here. We could just write STEMI, okay? All right, could we be more specific than that?
Yeah, where's the STEMI
Elevation
at?
Yeah.
in 2, 3.
Septal, interior?
That would be in your objective.
So our diagnosis wouldn't be an inferior MI if it was an inferior MI.
Well, hang on, you said something different, okay? If your diagnosis is an inferior STEMI, okay, that's your diagnosis.
In your objective, though.
In your
maybe-
objective, you write ST elevation in leads 2, 3, and AVF. Okay? Good there? All right, let me talk to my EMTs. You two shut up. Okay? Let's change the scenario. Bernie and Sarah, you guys are out on the medic unit at 2 o'clock in the morning, okay? You've got a guy who fell out of a tree. Don't ask me what he was doing up there at 2 o'clock in the morning, it's Finley, okay? Fell out of the tree. You arrive on scene, you flash the light on his leg, and his femur is sticking out of his leg, okay? Out of the skin, poking at you, waving, all right? What's your assessment?
Open femur fracture.
Wonderful. Open femur fracture. Okay? We good with that? I don't need to write, hey Doug, rule out that this guy's got a femur fracture. No, he's got a femur, that's, I love that one. Possible femur fracture, really? Possible? It's sticking out of the leg waving at you, okay? All right? Our little old gal, she already had really bad kyphosis. Kyphosis is when you lordosis, your back goes this way, kyphosis, your back goes this way. She's already kind of like this. So she's sitting in her chair, which a wheelchair, and every week she counts her meds on her little foldable dining table or
TV tray.
stand, TV tray, right? While she's doing this, she falls asleep, okay? And when she falls asleep, she rolls out of her chair. Her head hits the ground. She snaps her C2, okay? So now her head is hanging down like this, okay? And she fractures her humerus clean in half. And when I arrive, then this tough old bird drags herself side military across the living room floor, okay, to where the phone is, reaches up, manages to get the phone up off the hook that's on the wall in the kitchen, calls 911. When I arrive, she cannot lift her head up, right? Why? Because C2's fractured, okay? So she's down like this, and this humerus in here, okay, she at one point was probably a heavy gal, and so now she's kind of literally a bag of skin and bones, okay? And this humerus is doing this. It is literally waving at me, all right? Because she is trying to move this arm, but she can't because it is snapped off in here. Okay, guess what my diagnosis was?
Broken humerus.
And neck, okay? I don't need to say, maybe, rule out, possible, okay? Was I able to treat her? Yes, why? Because I had two diagnoses, cervical fracture and humerus fracture, period. End of story, okay? Was I able to put a seat collar on her? No, okay, why? Because in my assessment, her chin could not be lifted up off of her chest, okay? Was I able to bandage this? We tried, but that frickin' thing kept getting out of there and flopping around, okay? All right, so write the diagnosis. Now, are all of them that clear and easy?
No.
No,
God, no.
but you still have to form a diagnosis, all right? So, this is my equation, and Hodges is stealing it from me because he likes it so much. Subjective plus objective equals assessment leads to plan. So there you go. I just made documentation a math class, okay? All right, when I read your subjective, I should say, they went on a patient who is 57 years old complaining of chest pain and shortness of breath. I want to see a subjective that flushes out more of that information because I'm already thinking based on the dispatch information that this person was having a cardiac event. I am thinking ACS, right? Acute coronary syndromes. So now I want to see an objective. I want to see an assessment that falls in line with a patient who, based on their subjective, is having an acute coronary syndrome. So what would I expect to see in my objective?
12 lead.
12 lead?
Position the person was in.
Position the person was in?
Lung sounds and chest.
Lung sounds, absolutely. Presence of pedal edema, okay? What else? An interpretation of vital signs that tell me whether this patient's stable or not, okay? What else do I want? Anything? Any changes with palpation of the abdomen, okay? All right, maybe a neurological assessment, okay? All right, what are the other possibilities besides that that could cause this? Recent infection, lung infection, pneumonia, okay? Recent trauma, okay? So all those things, right? Okay, so that's gonna equal my assessment. So I take my subjective plus my objective and I say, this guy, not open femur fracture, we'll go back to our inferior stemming, okay? This patient is having an inferior wall ST elevation MI, okay? All right, now, what do I wanna see here in my plan?
A plan matches that.
I wanna see a plan that is pretty freaking close to what the protocol here says of what I do for a patient having an ST elevation MI, okay? Does that make sense? Okay, and when I don't see that, we're gonna have a problem. Dr. Hodges is gonna have a problem. He's gonna wanna know, how come I'm not seeing a 12 lead? How come I'm not seeing an end-tidal CO2? How come I'm not seeing SATs? How come I'm not seeing this, that? How come I'm not seeing aspirin? How come I'm not seeing nitro? Okay, all right, so we have our diagnosis. Then we have our plan, okay? So our plan, and you could even write in parentheses a parenthetical protocol here, because that's really, your protocol drives that. And let me just give you guys a little word of caution here. Do not think that your plan must follow the protocol exactly, okay? One of the most difficult things for paramedics when they come out of paramedic school is to transition away from being protocol paramedics to being what I call thinking paramedics, okay? Now they think when they come out of paramedic school that they know a lot, and they actually do, they actually know a lot. The problem is their synapses have not all quite connected all those things. So they tend to fall into what we call the protocol paramedic, meaning they follow the protocol. Okay, that's fine, except that when you arrive on the patient, to the scene of the patient, and the patient rarely actually does follow the protocol, okay? And they're down here on step 12, okay? And you're like, well, but before I can get to 12, I gotta do 1 through 11, okay? So they do 1 through 11, and the patient dies because they didn't get ahead of them and jump to step 12. Okay, the classic example is a status asthmaticus, massive asthma attack. What's the first drug that we give a patient with an asthma attack? Albuterol. Okay, but what is the first drug we give when we walk in on the patient who's having an asthma attack, who's already used their albuterol, and when we arrive, they're sitting on the floor, looking up, they've turned purple from their shoulders up, and they're going,
Epi.
Epi 1 to 1,000. Right now. We're not giving albuterol. We're not giving racemic epinephrine. This person can't breathe. They are going to be dead. They are going to be in cardiac arrest in 30 seconds unless we give them Epi 1 to 1,000 right now. So realize that your protocol, again, needs to be in line with not only what you assessed, but the picture that you have painted with them. If you paint a picture for me of a patient speaking, a patient calling for shortness of breath with a history of CHF, you arrive on the scene, they're speaking in 2 to 3 word sentences, okay, with an oxygen saturation of 72%, okay? Do not answer this question. EMTs, what do I want to see on that patient right now?
Duo.
Huh?
O2.
No,
Duo.
no. EMTs can do CPAP, right?
We haven't, but,
Yeah.
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 In the BLS program,
I
we
want
can.
CPAP on that patient
Yeah, we
a
don't
minute
care.
ago.
We
Oh,
don't
we
care.
haven't.
You guys aren't carrying CPAP? You
No.
will be carrying.
We will be.
We're
You
gonna change
absolutely
some
will.
stuff on the-
Yeah, you will be carrying CPAP, okay, I'll give you that one. Okay, I'll give you oxygen. I'll give you oxygen. Okay, yes, I want oxygen on her. What I really want on her is CPAP. Because if we don't get CPAP on this gal right now, she may already gonna be intubated here in a few seconds, all right? But hopefully we can pull her back from the edge. Probably not. We're probably just gonna buy her enough time to get ready to intubate so it can actually be a controlled procedure, okay? But that's what needs to happen. So your plan needs to be written chronologically, okay? So, and you can get as specific as you want, you know? Responded, code 3, that's part of your plan. Now, some people will say you don't need to do that. Personally, I disagree. You can write BSI. Then you can write that you did ABCs, okay? Then you got your history, then your exam, then you took some vital signs, then you took an ECG, which means what? When you write ECG, it means 12 lead, it doesn't mean 4 lead, okay? Then you gave aspirin, PO. Why? Why did we give aspirin?
Worried about
Long silence.
chest pain.
Huh? Right. Aspirin PO for chest pain, okay? Without response, okay? Meaning the aspirin didn't appear to do anything for him, okay? Then I started an IV. Why did I start an IV? Huh? IV for meds, okay? All right? 18 gauge, left AC at TKO with 0.9% normal saline, okay? All right. At TKO, 150 cc's infused during transport, okay? All right, I have to write it as a medic, I can't write it as a.
Trending vital signs
Huh?
obtained.
Yeah, well, now, so here's the, say that again?
So we'll put one set, I'm sure you'll go back to that, but in mine, I usually will put baseline vital signs obtained, and
That is
then later, I'll put en route to hospital trending vital signs obtained, so they know that they've been
Oh,
monitored.
you're not putting what they are.
I will, and.
Okay, that's incorrect.
In the assessment, Todd does not want us to put a specific set anymore? I thought you said you were gonna
No.
put that.
In your objective,
Yeah, objective,
you put your interpretation of your
Yes.
initial vital signs.
yes.
And if you want, you can write initial, you can write trends, stable, finishing, you can write vital.
Signs right there.
It does not go in the plan.
Your vital signs
just that I did them.
Yeah, that's what I said,
Not-
I've obtained.
Oh, yeah. Or another thing I'll do, I'll write serial right here.
Yeah.
Serial vital signs, and that means I did vital signs every 10 or 15 minutes, whatever, okay? And then I don't have to write vital signs again.
What's
Okay.
PO with aspirin?
Or per oral. Is that all y'all?
No file on, hold on.
Okay. Okay. Okay, last thing.
None of you.
I ran out of whiteboard. The last thing you need to document, and I'm just gonna kind of write it here, okay? So we have our plan here. And then down here, we're gonna write our transfers. Okay? And our transfers, okay? This is what I was talking about earlier, where we talk about who we transferred this patient to, okay? We transferred them to the ER. Patient transported to Trios ER. Maybe you can put in there how, code 2, code 3, whatever, okay? Patient delivered to room 7, okay? Patient transferred to the bed, okay? Information passed on to RN Jones, okay?
Question about that. So on all of mine, I do the same thing, except I just say transfer to RN or transfer to MD. I never put the specific name.
ICD-10 requires you to put the name,
Okay.
last name, at least,
Last name, okay.
last name, yes.
Just for some of the people that will start writing medical reports for the first time, how you move them to the stretcher is relatively important in securing them to the stretcher.
Say that again?
How you move them to the stretcher
Oh, yeah,
and
absolutely.
securing them to the stretcher, calling in your report.
Is everybody good here before I erase all this? Okay. How are we doing on time?
Got 30 minutes?
Yep.
You got whatever you need.
Lunch, dude. That's what I need. Okay.
Do I need to order in pizza?
No, I'm trying to lose some weight. If they want, I got chicken and stuff in the fridge. Okay. Yeah. No, we're not gonna go past noon.
Do we need a 5-minute
Do
restroom?
you guys need a break? Jake knows I don't take breaks, but if you need a break, take a break. I can lecture for 6 hours without stopping, so if you guys need a break, take a break. All right, here we go. All right.
Pitter patter.
Okay, so now we're gonna talk about how we document, okay? How? Okay. How do we document? Written notes. Okay? What do those look like?
PCR?
Nope.
No? Okay.
A written note could be a piece of 2-inch tape on your leg that you write down stuff, okay? I hate that, but that's a written note, okay? Maybe a flow sheet, okay, is a written note. You guys are getting iPads for the medic unit, right?
Yeah.
Is it Eagle Vision or iPad? Is that the conversation? Is that what we're doing here? Okay, all right. In Image Trend, in Elite Field, in the EMS, and I don't know if you guys have noticed this, you have a button in the top left corner called, is it called Script? Do you have that? Can you pull up Elite Field? I just blanked out on what it's called. It's not called Script. What is it called? Anyway, it's no, it's not Notepad.
It's Notepad.
Is it Notepad?
I'm pretty sure.
Anyway, you have a notepad, and you can open that up, and you can take little notes about your patient in Elite Field without actually having to punch everything in, okay? So, the question about written notes is it discoverable? And what do I mean by discoverable? Discoverable is a medical term, okay? Excuse me, a medical legal term, okay? Meaning, is it discoverable by the lawyers?
You tell me, you need me to open it up?
You want it?
I can open it up.
Sure, that'd be great. Is it? Is it discoverable?
No.
Yes. Anything that you wrote on with patient information is discoverable horrible and your report better match it.
Did Hitler teach your documentation
Yeah.
class? Okay. Not necessarily true, okay? Generally, the answer is no, unless you attach your notes to your PCR. And there are some organizations that require all notes taken to be attached to the PCR. And if you do, it is discoverable. If you do, you're opening yourself up. Don't do that. I'm not suggesting falsification of documentation. That's not what I'm suggesting. But I'm trying to teach a class.
Must be a power outage.
There must be an automatic.
Yeah, see, that's what I said, I think there's
What
an
is it?
hour.
These are all
Fire alarms?
Yeah.
Oh.
That's what I said.
West End.
That's what I said when
Okay,
we had the
all right.
second one.
So just know that your written notes truly are for you.
So what if you do it on that,
It
does that
doesn't keep it.
automatically put it?
No, it
Oh.
doesn't keep it. That's why you wanna
Okay.
use that little
Okay.
notepad, cause as soon as you finish up the chart, it wipes it out. When
Okay.
it's only there in Elite Field,
Mhm.
and when you transfer the call up to the cloud, so that you can then go finish it up on the database, that note doesn't go with it,
Okay.
okay? We all good there? Okay,
Mm-hmm.
alright, alright. How else do we do it? Well, Zoll data, okay? All your Zoll data, okay, that is obviously collected and then transmitted. So your Zoll data collected and then transmitted, okay, becomes a part of the chart. Now, does that mean all of it needs to be kept in the chart? No. Okay, so we just turned on the perfusion index on our Zolls at Kennewick. And yesterday afternoon sometime, crew went out, gal, her perfusion index was like 0.9. And it was kept fluctuating back and forth between 1.2 and 0.9. And every time it dropped below 1.1, it went into alarm and it prints an ECG. And so when he got back to the station and he uploaded the documentation, he had 10 sets of vital signs with 10 ECG strips for the 10 alarms that this did while he was transporting this patient. And he is like, is this what you want? Do you want all of these in there? So I told him, no, go in and you can delete out the erroneous stuff that you don't need in there. The other thing that happens is, so I've got a patient, let's take our 14-year-old, okay? You're transporting her to the hospital, okay? And she's had an SaO2 of what? 100%. But then during the transport, the SpO2 slipped off her finger and fell on the floor, and you didn't notice it until it started to alarm, and it said her SaO2 is 65. Okay? Well, when you upload that into ImageTrend, it's going to have a vital sign of a SaO2 of 65. Is that true? That's not true. So you need to go in and you delete that out. So just because it took the vital sign and it transmitted the vital sign doesn't mean you have to keep it in there. Does that make sense? Okay. All right. All right. This one's pretty obvious. Written charts. Okay? Who writes the chart? Huh? Paramedics write all charts, right? Can we all agree on that?
Sure.
Sure,
No,
I'll go with that.
It's not true.
How about the
Not
person
true.
that's in charge of the call?
Primary patient.
Lead EMS provider. Okay? So if Bernie says, hey, I'm gonna tech this call, and he initiates contact, and he introduces himself, and he gets permission to treat, or to assess and to treat and to transport and all that, Bernie's the lead, period. End of story, okay? Now, Samantha might say, all right, Bernie, so what do you want to do next with this patient? And Bernie's like, I think we got everything we need, let's just get on the cot and get going. And Samantha says, well, Bernie, I know you were in the Army and all, but should we put a traction splint on that broken leg before we move the patient? Kidding with you.
Water and motor.
Huh?
Water and motor.
Water and motor, you'll be okay.
Rub some dirt on it, right, brother? All right. So now she gave some input. Okay. Now, Bernie's like, okay, you're right. All right. I forgot this guy's from the Air Force. He can't get up on the cot with a broken leg like an Army guy could. So, all right, we'll put a splint on him to get him going. All right. So Bernie stays the lead on this call. Now, in QA, we're reviewing this. We're like, all right, Bernie did a pretty good job. Okay, but who else was on this call? Oh. Then we're gonna have a conversation with Samantha. Samantha, why didn't you take over care of this patient with a broken leg, start an IV, give him some fentanyl, do some of those nice things we do for the human race, okay? And that's a totally different deal. But Bernie is still the lead, because he teched the call all the way through. Does that make sense? So just because maybe it should have been Samantha who teched the call at the end of the day, Bernie teched the call, so Bernie writes the chart. All right, does that make sense?
Mm-hmm.
Now, let's twist this a little bit. They've responded to a 86-year-old female who's been complaining of a slow onset of chest pain for the last week, and it's right there. And now she's having some difficulty breathing, and she's got this unproductive cough. And we take her temperature, and it's 100.8. Okay,
Sepsis.
huh?
Sepsis.
Pneumonia for sure.
Hi, pneumonia.
Okay.
Coronavirus.
Coronavirus, yeah. Okay.
SARS.
And so Sam's like, I think we're okay with where we're at. I'll let what's your name?
Ryan.
I'll let Ryan continue to tech this call, but I do want to do a 12 lead. All right, so let's do a 12 lead. Okay, good. We've ruled out ACS as far as we can tell. Okay, the presentation, the story. You got to remember this, you guys, when you're charting. 80% of all diagnoses is history. 20% of your diagnosis is your findings. Okay? That is the breakdown of almost every diagnosis. You ask any ER physician, what percentage of your diagnosis is history, and they will invariably say around 80%. So, if you listen to this gal's history, sure sounds a lot like pneumonia, okay? But what Sam might choose to do is say, you know what? This is an EMT chart, I'm good with that, but I'm gonna write an addendum, okay? And she's gonna write an ALS addendum, okay? In which she's gonna say, assess patient for ACS, did X, Y, and Z, performed 12 lead with no findings, yada, yada, yada. Okay, that's one reason to do an addendum. What's another reason to do an addendum?
To cover me.
Huh?
You
Cover
forgot
myself.
something.
Right.
Yeah.
So they get done with the call, and you guys have been getting slammed. I mean, Ben one, geez, you had what, 3 calls in a day? Let's slow down here, right? Come on. So I wish Loparco was here. I could really have fun then. All right. So they get done with this chart, and then Captain Henderson calls Sam and says, hey, what gives you? Why do we have a guy with a femur fracture, and we're letting the EMT tech the call? Why, we don't have an IV, we didn't give any analgesics, what's the deal? Samantha says, oh, I did all those things. You did? Yeah, ask Bernie, he'll tell you. Oh, you did do all those things, great. Why isn't it charted? Sorry, we got super busy, we were out on a wildland fire till forever, for 2 weeks, okay? I totally forgot that I started an IV and gave that guy fentanyl. Okay, so Bernie probably should have written the chart, it probably should have been you, but now, will you please go in and add an addendum? Okay, now, where do we add an addendum in image trend?
The bottom little.
Exactly, so first of all, let's look over here. So what's, the notes thing is called what? There it is. Man, oh wait, no, you're not reading my mind. Uncheck that, please. like worksheets. No, it's not worksheets. Where is it at?
I thought it was at the end of the narrative.
Yeah, it's,
Go to the narrative, Darren. Over on the left. The
No,
narrative, go down below it.
no,
Okay.
it's right here.
Oh, that's in the,
I wonder if
Fire
we turned it
report.
off. Anyway, I gotta look, notepad should be there, it should be right here, where you can click on it, you can write notes. Oh, that's why, you're not in Elite Field.
yeah, you're not in.
You're in Elite Web, you're not in Field, that's
Hmm.
why. Oh wait, yes you are, cause you got a
No.
post button. Huh. Anyway, we'll figure it out, but it should be right here, right above situations, I think is where notepad is. Anyway, that's where you do that. So, to do an addendum, the right way to do an addendum is to click menu, click addendum, okay, add new, and now you can add in your description of what your addendum is. And you use that whether you're changing something that you documented, that you should have documented better. Like maybe Darren calls you up and says, hey, you didn't document how much fluid you gave this patient, okay? So last night, I get home, I'd been out somewhere and I got home about 8:30 and I look at my work phone and I got a call from the organ center, because whenever you have a cardiac arrest and a death, then there's tissue donation. And I've had 2 calls from them this week already on how much fluid did you give the person, because you can't donate your corneas if you got too much fluid during the resuscitation. So I pull up the chart, how much fluid they give. Well, they wrote in the chart, initiated infusion 30 cc's per kilo. I look at the weight, 79 kilos. Great. This guy could have gotten as much as 2 liters. I looked through the chart. Nowhere did they chart how much fluid they gave. So I'm like, gotta call you back. Call the crew at 9 o'clock at night. I'm like, how much fluid did you guys give? Oh, only about 450. Okay, that's not in your chart. So ideally what they do is they then go into their addendum and they write 400 and, well, first of all, you write addendum, even though you're putting it in the addendum thing. Then you write something to the effect of regarding fluid administration, okay, 450 cc's infused at end of resuscitation efforts, okay? Then you put your name, okay, Eric Nilsson, paramedic, date, time. That is how you properly do an addendum, okay? All right? We all good there?
I have a technical question about it.
Please.
So about on the side of this,
Yeah.
can they log into their own profile and add an addendum, or do they have to be through my profile? Like, say I was the one doing the BLS report,
After the chart is up, in not an Elite Field,
but you posted it?
but once you've posted it, then yes, they should be able to go, if, provided they were a crew member on the call, they should be able to go in and add an addendum.
Okay.
Yeah. I would make sure you're not in that call when you do that. You don't both want to be in that call at the same time. You'll overwrite data.
Right.
Yeah, okay. All right. So the other one that I have in the list is digital data, which really is your Zoll data, okay? But you might, yeah, that's probably it. Okay, the next one, so we've talked about addendums. The next one is collected information. And that could be face sheets, that could be med lists, that could be a 12 lead from an urgent care, all kinds of stuff, okay? And then, and I guess we could include it in the same list, but I want to draw special attention to it, and that is pulse forms, okay? So you guys have a pulse form in your handouts there, okay? Select a pulse form, okay? Okay, I want to talk about some special situations here real quick. It's in, yeah, there it is, it's in the very back, okay? It's in your packet, very back of your packet. the golden rule is this: any patient with a post form that gets transported to the ER, the post form should go with them. Okay? All right? Now, it used to be you couldn't take the lime green copy, or excuse me, you couldn't take photocopies of it. You had to have the original. They've changed the rule on that now. You can now take a photocopy. You can also snap a picture of it and take it with you. So they're like, well, we only have this one copy and we don't want it to leave the house. Okay, but the post form has to go with the patient. If the patient dies in the ER and the post form's out on Bowles Road, that creates a problem, okay? Excuse me, yes, you could take a picture of it, and that's all good, but that doesn't stay with the patient necessarily, which we're gonna talk about real quick before we're done here. So ideally, take it with you, okay? If you absolutely can't, take a picture of it, include it in your documentation. Now, do you guys all know how to take pictures with your, you don't have iPads yet?
Not yet.
Okay. So
Do I know how
Captain
to do
Henderson
that?
is gonna teach you how to capture documentation with ImageTrend with your iPad. There's a good way and there's an okay way. You wanna do it the good way, which is actually the best way, okay? Because the okay way to do it keeps a copy of it on the iPad. The best way does not, okay? You do not want to keep copies of documents or pictures of scenes on your electronics, okay? Because then it is what? Discoverable, okay? All right, and when they say, give us all information about this motor vehicle accident, and you don't give them the pictures that you had on that iPhone or iPad, and then they find out that you didn't give them everything that you had, tisk tisk, pay me, okay? You don't wanna do that, all right? Okay, so post forms, all right. So we all good, any questions about post? I could talk about post forms for an hour, so I'm just really touching on them real quick. If they have them, take them, okay? We all good there? All right. Next, I wanna talk about refusals. Now, I know you guys are all gonna watch Dr. Hodges' videos now, so let's turn to your refusal protocol there.
G13.
I want you to do two things. I want you to not only turn to your refusal, but I want you to grab this document right here, okay? Everybody see this? It's a standalone sheet, I think, isn't it? Yeah. Standalone piece of paper, you guys have like this, on the back side of it. So this, first of all, let's, hang on. Before this, let's talk about patient privacy notice, okay? Every patient that you, well, let me just say it this way, because that's a redundancy. If I just said every patient has to get one of these, what does that mean?
Every patient needs to get one that you.
But who's every patient?
Back to.
Every patient that you collect PHI from and or do an assessment, right? So what this document here says is it is a legal binding statement of what you will and will not do with their PHI. Are you an EMT? Okay, you got lucky, man. I just suddenly realized I haven't picked on you the entire time. We were about to get a fire hose, all right? But since you're not an EMT, you get out of jail free card. Okay, so every patient has to get one of these, period, okay? KFD is doing horrible with this right now. I am beating up our people about it because we used to do really good when everybody used to sign the back of it, but now that they sign digitally, they forget to give them this. They still have to get this. This is their right, okay? Because they have a right to know what you are going to or not going to do with their private health information. Okay, that's that. On the back side of this is something I'm really encouraging Darren to get for you guys to start off on the right foot. You guys already got, you getting this going? Working on it, excellent. So what this enables you to do, you guys go on a patient, and then we'll keep this BLS, okay? So Rob and Bernie and Sarah go out on a 50-year-old female who says she feels like her blood sugar's getting low, okay? You guys get there, she's got a blood sugar of 50. Is that low?
Yeah.
Moderately low, right? But she can talk and she can swallow, she can communicate, you know, she knows what's going on, she's alert and oriented 4 out of 4, and you give her 15 grams of oral glucose, right? Do you guys like the lemon or the cherry, or the grape? The grape is the best, huh?
They got the grape the last time.
Yeah, it's the best anyway. All right, so you give her the grape, all right, and now after a few minutes, you take another blood sugar, and her blood sugar's up to 60. Okay, well, your blood sugar's going down. So what happened? How did this occur? You know, oh, I wasn't paying attention. I just took a little bit too much insulin, but you know, it's the Lantus. It's not long acting. I'll be okay. So you call into the doc, and then you explain to the doc what happened, and your blood sugar is trending up. And the doc says, oh, I think it's reasonable. The insulin she took is medium acting, so I think she'll be okay. Is there somebody there to watch her? Yeah, her husband's here with her to watch her. Okay, great. I think we're doing pretty good. She absolutely does not want to go to the hospital. She's confident in how this happened. All right, so then you say, okay, so Ethel, here's what I need you to do, okay? I need you to check your blood sugar every 30 minutes. Can you do that? And I need you to do that for the next 4 hours, because that's the duration of your Lantus that you took. Okay? Can you do that? Yeah? Husband, you're on board? Yeah? Okay, great. I'm going to write that down. Okay? Next, I want you to eat a peanut butter and jelly sandwich and drink a glass of milk. Why?
Long acting, keep the
I
blood
want
sugar
some
up.
protein, I want some carbs, I want some simple sugars. Okay? And who can eat a PB&J without a glass of milk, right? Okay. All right. So you're going to do that. All right? With a PB&J? Do you have a problem?
Yes,
That is a problem.
there's more than you know.
All right. So then you write out these instructions that you want her to take, right? Okay. So she's going to do those things. Then I want you to call 911. In fact, when I built this form, I almost hard-coded it into the bottom because it should be written every freaking time you do a refusal. I want you to call 911 if the symptoms persist or return. Okay? Period. The reason why I didn't write it in there is because I wanted to roll off the lips of the EMS provider. I want them to say it out loud. They really need to say it, okay? When you guys watch that video from Dr. Hodges, here's what he will tell you. He will tell you about patients that he sees in his ER that come in POV that had previously called 911, and they tell the doctor, well, I called 911, but they said I didn't need to go by ambulance. Dr. Hodges does not like to hear those words, okay? They also say, I would have called back, but they already told me I didn't need to go by ambulance, so I just figured out a way to get here myself. Okay? All right. So you're gonna write those instructions in. Then you're gonna take your iPad, you're gonna snap a picture of it, and then you're gonna say, here's your private health information rights, and here's your instructions. You good? Can you do that? Yeah, my husband can help me make the PB&J. Excellent. Husband, you've got this? You're all good? All right, wonderful. Now we've got documentation on both sides. They've got a copy of it, you've got a copy of it, so that when you upload it,
That's chief, sorry. Sorry.
well, he's calling you to tell you it's your last day.
It's the last day, yeah.
Yeah. You
I'll
better
answer it
answer.
later.
You better answer.
I'll call him back.
Did you lose your keys again?
Where did Trish go?
You know this is being recorded for viewing at a later date.
It's all right.
Okay, all right. Any questions about that? Pretty straightforward?
And time. Beautiful.
That's it. No questions, comments, controversy?
Spanish form, do you have a Spanish form that you carry, so we could maybe get a copy?
We do have an old Spanish form, and we need to make it in that form that we don't have. We have the waiver in Spanish, I don't have the refusal piece in Spanish. And the whole reason why I haven't done it is because I ain't got nobody who can write in Spanish.
Bernie?
No, that's not what I mean. My medics can't write in Spanish.
Yeah,
You would
you
need to
have
be able to write,
Spanish.
you know,
Oh, like on a
Okay,
call.
yeah, if you're
Yeah.
gonna write instructions to somebody who's Spanish speaking, you need to be able to write Spanish.
So my view on it, or what we've run into with me working in Spanish, is that it's our burden to make sure that they understand the risk of refusal. So if I say that, and I have them sign an English form, and say that I used an interpreter,
No, I,
then
okay.
O and
they,
A and speak louder.
signed in English form, so how can we prove that they knew what they were signing? As where if I
They
used
did.
an interpreter and I documented that, and then I let them also read it in Spanish and sign a Spanish form, then I'd pass it
No,
on.
and that's all good, I totally agree with you on that, what I'm talking about is in the instructional piece.
Yeah.
You would need somebody who could write in Spanish.
Do we, or could we just write in English and then document that we used an interpreter? That it also.
I
verbally
suppose that would be
explains.
better than nothing, but it still wouldn't have the weight of giving them those instructions on 911.
Where does the patient sign it?
Can we write that in?
It's not something for them
Oh,
to
they're
sign.
actually signing on.
Their signature for refusal happens in ImageTrend on the tablet.
Gotcha.
That is just documentation that you informed them of what to
And
do,
you're leaving this with them.
and you're leaving that with them.
We need to alter this because we don't have the
Calm down.
iPads and we're not going to for probably a few months, right?
What's that, sorry?
When are we getting iPads?
As soon as I can try and,
Before transport or after?
I would like to try and get them before transport.
Oh, okay, well then that would be great.
You can have them by
Well,
Friday.
so our
They're not that hard to get.
I know,
You
it's
gotta set
super
up.
simple to get.
We gotta set up.
You could